Hello, everyone. My name is Vinicio de Jesus Perez. I'm an associate professor in pulmonary medicine at Stanford University and staff physician of the Adult Pulmonary Hypertension Clinic. Today, I would like to tell you about the diagnostic evaluation of the patient with pulmonary hypertension at the clinic. Most patients who arrive at our Stanford Adult Pulmonary Hypertension Clinic are being referred by clinicians in the community due to abnormal findings on an echocardiogram. The first step is to educate the patient on why they have been referred to us. For many patients, they really are confused because they start the workup at their referring physician's office because they're presenting with shortness of breath, and initially they're thinking of asthma, air pollution, reactive airway disease, or they're just simply having anxiety attacks. And all of a sudden, an echo shows that they have some abnormality in the heart. So the first step is to address the patient's impression of why they have been referred, explain our role, and why the referring physician asked us to be involved in the care. Once we get through that, the next step is to obtain a detailed clinical history for the patient relevant to what we have identified as the major risk factors for pulmonary hypertension. At our clinic, we make a strong effort to capture a detailed drug exposure history, given that many of the patients we see have been either prior users or active users of stimulants like methamphetamine, which our group has identified as a major cause of pulmonary hypertension. In addition to that, we discuss a family history that could suggest that the patient may be suffering from hereditary pulmonary hypertension. We also talk about a history of clots or, for example, if they've had issues in the past with cancer, heart murmur, suggesting potential clotting disorders or the possibility of a congenital heart disease. Once we get a detailed history and we perform our physical examination, we also review the diagnostic studies available to us. In most cases, what we will do is we will repeat the echocardiogram using our protocol for assessing the right ventricle, which allows us to capture not only morphology, but also measures of function. We will complement this by obtaining other studies to look at the anatomy and function of the pulmonary system, such as pulmonary function studies, CAT scans. We will use a VQ scan to look for evidence of obstructive anomalies that may correlate with evidence of clot in the pulmonary circulation. Some lab work that we routinely obtain is HIV, as well as serologies for autoantibodies, which may correlate with evidence of connective tissue disease. In our clinic, we are also very aggressive about obtaining urine toxicology, especially in patients where we have a high suspicion that they could be using methamphetamine. Once we have this, the patient will return to us within a month to go over the findings and to plan for the right heart catheterization. Prior to starting medical therapy in our patients, we will obtain a right heart catheterization since it's the gold standard for the diagnosis of pulmonary hypertension, and it will tell us which clinical group the patient belongs to. This is critical because, as most of you know, the currently approved FDA medications for pulmonary hypertension are only approved for group 1 pulmonary hypertension, with the exception of riociguat, which is approved for group 4 or chronic thromboembolic pulmonary hypertension. So we want to make sure that the patient is a candidate for this compound. So the right heart catheterization that we perform here goes through the entire hemodynamic characterization. We measure pressures, we capture cardiac output index. We also perform vasoreactivity testing, which is a tool that allows us to determine whether a patient has an acute response to inhaled nitric oxide, which will ultimately inform us whether the patient may benefit from the initiation of calcium channel blockers. But we also do other maneuvers within the study. We look at the evidence of potential communications between the two sides of the heart, which may suggest the presence of a congenital heart defect. We can also look at the anatomy of the pulmonary vascular tree by doing wedge angiograms or using contrast to delineate if there's a presence of an obstructive clot, which is critical if we're thinking that this is a patient who may suffer from chronic thromboembolic pulmonary hypertension, as this will help plan a surgical intervention, whether it's a thromboendarterectomy or a balloon angioplasty. Once the patient gets the right heart cath, patient returns in a week to discuss the treatment options. We will explain in detail how the data fits into a given clinical classification. We will discuss the therapeutic options. And again, depending on the functional status of the patient and how high the risk of your mortality is, based on the use of the REVEAL rescore, we will then plan the therapy, which of course will involve the use of endothelin receptor antagonists, PDE5 inhibitors, riociguat, or specific prostanoid. The most important thing for us is to make sure the patient feels that we are taking his or her condition seriously and that we are there to educate and support them throughout the entire process. Pulmonary hypertension is a lifelong disease, and we are going to be involved for the entire duration of that experience. And our goal is to make sure the patients don't feel alone, that we are there to support them every step of the way. Patients who come to our clinic, they have an opportunity to meet with our nurse practitioners and social worker who will also identify specific challenges to that patient, namely issues regarding insurance coverage, social support, disability. Patients are also referred early on to palliative care specialists. One thing we make very clear to patients is that discussing their case with a palliative care specialist does not mean that they're at the end of the road or we're considering hospice. On the contrary, the role of the palliative care specialist has evolved and has become now a huge part of our early initiatives in the diagnostic and treatment of patients with pulmonary arterial hypertension. What the palliative care specialist will do is to make sure that the patient is having an appropriate quality of life while getting treated for their disease. For instance, many patients with pulmonary hypertension complain of chronic pain, anxiety secondary to chronic dyspnea. Patients may want to spend more time at home than coming to the hospital. These are all things where palliative care specialists can offer their assistance. The other item that is of importance is that our palliative care specialists also help our patients discuss end of life care, as well as to address issues regarding their code status and next of kin when it comes to taking medical decisions should the patients become incapacitated. I think in this day and age, it is a group approach to the care of a patient with pulmonary hypertension. Patients with pulmonary hypertension have multiple needs that go beyond what me as a pulmonary hypertension practitioner can offer. I think we are all aware that in order to treat pulmonary hypertension, we need to treat the patient as a whole, and that includes their psychological status. It also means trying to talk with the caregivers and the family so that they're educated and they feel that there's a lot of support for their loved one who's dealing with the condition, as well as for them who have to support someone who's got a chronic life-threatening disease. I can say that one of the greatest satisfactions for me in being part of one of the largest pulmonary hypertension centers in the United States is that we do have these resources that we can offer patients. I feel that this allows us to make a big impact on a patient's quality of life, and independent of whether we can cure the disease or not, our goal as that patient's provider is to reduce suffering, provide hope and support, no matter the stage of the condition, and ultimately be part of that journey and be as supporting and careful as we can. My name is Vinicio de Jesus Perez, and I am aware that I'm rare.